Hello and welcome to this podcast on motivation interviewing in healthcare settings. My name is Jay Suhan. I'm a clinical professor in the departments of psychiatry and family medicine here at UC Irvine. Today, what I'd like to do is review the spirit and the principles of motivation interviewing. Then I'm going to utilize these four processes of MI to illustrate the flow of MI. And then finally, demonstrate some key skills that we use to assist our patients towards health behavior change. The two textbooks that I draw from during this presentation are the Motivational Interviewing, Helping People Change. It's the third edition by Miller and Rolnick, as well as Motivational Interviewing for Healthcare Professionals, A Sensible Approach by Berger and Vallum. And I will just give a special thanks to Dr. Lawrence Brown, who helped in the creation of this presentation. So what is MI? It is a patient-centered counseling style for addressing ambivalence about change. This approach began in the substance use disorders world, but we quickly found that really has a broader application and effectiveness when it comes to working with our patients about lifestyle modifications, for example, weight loss or diet, but also when patients are expressing some ambivalence or concern about a treatment, a medication treatment, or taking a medication. And it really thought even more broadly than that, if you're working with a patient and you find them sort of expressing skepticism or withdrawing from the conversation, we find that using motivational interviewing approach can really help to re-engage our patients. Now, this approach is not the only approach that we use in medicine or counseling style. In the very acute settings, for example, in the emergency room, if there is just an emergent situation like a broken bone or we're concerned about a heart attack, we may be very directing. Right. So there may be a very clear, correct answer. And we as a clinician are going to be very directive in telling the patient what to do. There is also the opposite or more of a following approach. And examples of this is when the patient is asking about maybe having another child, or maybe you're giving some bad news to the patient. There really is no correct, right answer. And so we're going to be much more patient-focused, and we're going to be more following the patient's lead. Motivational interviewing is somewhere in the middle between these two, where it's really more of a guiding approach. So there is a correct answer, but it's not an acute situation. And so in these situations where it's not acute, it's a chronic illness or a behavior, we find that a more guiding approach is going to be more effective. Now, in order to understand motivational interviewing, it's really useful to understand the spirit and the principles of MI. The spirit can be thought about sort of like a 10,000-foot view of MI, and the principles is maybe a more zoomed in picture, maybe 1,500-foot view where you can really make out some of the details of where we're trying to go. And then there is the actual tools or skills of MI that are really at the ground level that we'll get to. But we think about, though, the spirit and principles. The four principles, the elements of the spirit are partnership, acceptance, compassion, and evocation. Partnership really means that rather than an interrogation of the patient, it is a collaboration. And we're going to, that's going to manifest with curiosity and empathy with what the patient is going through. When we say that we have acceptance for the patient, what we're saying is that it's really ultimately the patient's final decision of what's going to happen next, right? Because we're talking about non-acute chronic illness situations. And that if the patient doesn't want to do something, they're not going to do it. And that we're going to roll the resistance rather than continuing to hound or hassle the patient into doing something. When it comes to compassion, it means that we have the best interests of the patient in mind, and that we're not really using MI to trick the patient into doing something that they don't want to do. In fact, the aligning principle to that is supporting the patient's self-efficacy. The more control that the patient feels, what we find is the patients generally end up doing things that are in their best interest and are healthier in behavior. And finally, the evocation, and this really means that the best ideas come from the patient. And our job is to support that. The aligning principle often is that we can find that developing any discrepancy between the patient's expressed goals and their current behavior often is very helpful in helping the patient recognize which behaviors they want to change. Now, when it comes to the skills of motivational interviewing, so these are the actual boots on the ground ways that we're going to help people change and change their behavior. It's useful to think about these skills on the roadmap of the processes. So the processes are engaging, focusing, evoking, and planning. So if we think about a patient where we've identified an unhealthy behavior like smoking, or it could be not taking a medication, we might have seen that in the chart or in our initial early conversation with the patient. We're in the engaging process. So that's where we start. And we're going to use some very specific foundational skills. You can see here the POARS skills. And we're going to start that early, and we're going to use it all the way across to behavior change. But in this engaging process, we're going to try to get a good understanding of why the patient is doing that unhealthy behavior. In the focusing process, it means that we've been able to gather the why of why they're engaging in the health behavior and develop some strategies as how to address them. The evoking process illustrates that we use some very specific skills at this time in this process to help them move towards change. And then if we're successful and the patient is ready, then we enter the planning process, and we have specific skills there as well. So you could see here that we don't use our motivational interviewing skills or MI skills just randomly, but rather there are specific processes where they really come to bear. And that's really important to know. And it also is very helpful so that you don't end up getting confused as to which skills are used when. Now, and I think an important thing to point out here is that moving through these processes can be in a single visit, or it may be over multiple visits. So you may be able to identify at the beginning of an appointment some unhealthy behavior, and if sometimes you're able to move through engaging, focusing, evoking, and planning all within 10 to 20 minutes. But in other scenarios, it may take multiple visits and months in terms of the time gone by before a patient is ready to move to planning and engage in health behavior. So let's start with the engaging process. So as I mentioned before, we're going to use our POARS skills, which we'll get to. And the goal here is to understand the patient's perspective and situation leading to this unhealthy behavior. And at the same time, we're also at this early stage trying our best to build rapport. Now, when understanding patient perspective, there's a specific term I'm going to refer to, and it's called patient sense making. And this is how a person makes sense of an illness or a treatment based on that person's knowledge and experience. And this is important because the sense making leads to the health behavior. So if we have any hope in trying to evoke change in that behavior, we have to understand the sense making. So how do we do this? We use our POARS skills. So what is the P? P is asking permission. Can we talk about your blood pressure? Can we talk about your diabetes? Why do we do this? Well, it is supporting the patient's self-efficacy, because the patient may choose not to want to talk about that issue at that time, and we're going to respect that. But what you find is that if you ask permission, more often than not, the patient is going to be more willing and open to talk about it because you've asked permission. Open-ended questions is the O, and open-ended questions begin with how, what, when, where, who. And what we're going to be asking are, what does the person feel about the behavior? What are their ideas and what do they know about diabetes? What do they know about hypertension? How are they functioning with or dealing with diabetes, hypertension, obesity, whatever it might be? What are their expectations if things remain the same? What are their expectations if things change? What is their previous experience with trying change? So all of these questions are meant to explore the patient's ideas and to get the patient's sense making around the behavior. And at this point, we're using these open-ended questions to explore. We're not trying to change the patient right now. We're not trying to evoke change. We're trying to just understand what's going on. And the other elements of the POARS skills of affirmation and reflection are these two elements are used in response to the open-ended questions. So if you ask a question and the patient gives you some element of their sense making, we want to look for opportunities to reflect and to affirm. So a reflection, simply stated, is to restate what the patient says. It seems that you are having a difficult time with taking your medications, as an example, right? We're not trying to advise the patient. We're not judging. We're not correcting. We're just reflecting back. And there are actually a number of different ways to reflect. We're not going to get into those today, but simply stated, it's restating what the patient says. Now, affirmations are sort of a specific or a subset of a reflection, because affirmations are positive comments on a patient's strength, effort, or intention that you're hearing from them. So if the patient says, maybe they've intended to walk 5 days out of the week, but they tell you they've walked twice out of the week. Rather than focusing on what they haven't done, what we would do is to focus on what they did do. You walked twice this week, despite the fact that it was raining, as an example. If they didn't drink 1 day out of the week when the kids came over, you might say, being a role model for your kids is important for you, and so you didn't drink that day. So we're looking for elements here where they are trying to make a difference rather than focusing on the negatives. So the S stands for summarize, and this is essentially a collection of reflections. And oftentimes this is helpful because this can help confirm for us if we have the sense making and if it's correct. So if we do this, what we're doing is we're building rapport, right? So the open-ended questions are to get or explore the sense making, whereas the affirmations, reflections, and summarizing are really there to build rapport, because we're basically saying, I'm hearing you, I'm listening, and this is what I think I hear. And if you think about it, if a person is telling you or parroting back to you what you're saying, it tells you that they have been listening, and that's how we build rapport. So what does this look like, on the ground? So this is just a simple example of how this may go with a patient. So we may start with, can we take a few minutes to talk about your blood pressure? That's asking permission. Patient says, sure. I ask an open-ended question. I've noticed your blood pressure has been high in the last 2 visits. What are your thoughts about that? Well, I know my blood pressure, high blood pressure can cause heart attacks, but I've been feeling fine, so I guess it doesn't bother me too much. So my reflection to that would be, if it were causing you symptoms, you'd be more worried about it. The patient says, that's right. My open-ended question would be, so how often do you take your lisinopril? I'd say about 2 or 3 times a week, because things get kind of hectic. So despite things being really busy, you still try to take your medications when you can. The patient responds to that affirmation. Yeah, I take it when I can. So a summary here is, so on the one hand, you know that high blood pressure can lead to heart attacks. And on the other hand, you've been feeling fine and life has been hectic. So it's not been a priority for you to take your medication every day. So this is an opportunity for the patient to either sort of say, yes, that's exactly what's going on, or to correct us. And if they correct us, that's fine, because that means we're fine-tuning our sense making of what's happening. So that leads us into the focusing process of MI. So now that we have gathered the sense making, we need to assess it. So here, for example, the patient's sense making is, I feel fine, so high blood pressure isn't a big deal right now, plus my life is hectic. And both of these elements, or both of these premises, are leading to the behavior of the medication not being taken regularly. So there are two premises here, right? The first one, I feel fine, so high blood pressure isn't a big deal right now, is what we call a factual premise. And it's a factual premise because it is a medical belief, and that may be addressed by our medical expertise if we do it well, okay? And if we do this appropriately, we may increase the patient's sense of importance for change, okay? We can also screw this up if we don't do this well. The second element here, or the second premise, I should say, is the motivational premise. And a motivational premise is a personal situation blocking change, okay? So not a medical belief, but this is a personal situation. And if we're able to address this successfully, then the patient's sense of importance may go up, but even more, the patient's sense of confidence for change can go up. And this is important because each factual premise is addressed in a different way than a motivational premise. So here are some of the other examples of sense making. So if a patient has struggling with obesity, and the patient tells you that going to the gym is really kind of embarrassing, so they haven't been exercising, and they really eat when they're stressed out, and that's leading to no weight loss. Both of these are motivational premises. They're not factual, right? In the case of someone who smokes, patient may tell you that, well, it's really a part of their daily routine. All their friends drink. Oh, I'm sorry, I got them mixed up. So this is tobacco use disorder, but all my friends smoke. And the patient says to you that they're feeling shaky and they have cravings if they don't smoke. And so what does that mean? Well, that leads to continued smoking, right? And you can see here that the shaking and the cravings if I don't smoke we may be able to address that through a factual, because that's a factual premise, through medical information. But the part of my routine and all my friends smoke or drink, those are motivational premises, and we need to handle those differently. So let's first talk about, now we're in evoking change, right? And we're going to try to evoke a change in a factual premise. So back to our example, I feel fine, so high blood pressure isn't a big deal right now. It may be tempting to respond to this factual premise by saying something like, you have to understand or realize that, you're not doing fine, that high blood pressure is a problem. The issue here is that is not the patient's lived experience. It's not going to resonate, right? You may be tempted to say, well, just because you're fine, it doesn't mean that you're doing okay. So in this case, you're just dismissing the patient's sense making. Or you might just resort back to, well, it's just really important that you take your medication. We're just going to completely ignore how the patient is making sense of the situation. So all three of these have a problem in that the patient, we say, loses face, that you're basically downplaying what the patient is thinking, and what you're risking is losing rapport. And as I mentioned, rapport is important. So we want to try to figure out a way to provide information without the patient losing face and without losing rapport. So how do we do this? We need to make sure that the missing information that we provide, first of all, it makes sense to the patient. So we may want to use analogies, and we certainly want to avoid jargon as much as we can. But also, very importantly, we want to make sure that the information that we provide directly addresses the patient's sense making and adds to the sense making rather than correcting the sense making. So if you think about the patient, the way that the patient's thinking about the behavior as a lock, we want to make sure that our medical information is a key and that that key fits the lock, right? We can't expect the patient to fit our medical information. It needs to be the other way around. And we need to do this in as neutral a form as possible. And oftentimes the way that we can avoid it being biased is by avoiding the word you during the explanation. So what are some examples of what I'm trying to say here? So the medical information, an example could be high blood pressure causes no symptoms early on, but over time that constant pressure can weaken blood vessels. And at some point, these weakened blood vessels can leak or burst, and a person feels it as heart attack or stroke. Or if you want to use an analogy, you might say, if we think of blood vessels like a garden hose and high blood pressure like leaving the water on full blast all the time, the hose will weaken over time and more likely to leak or burst. So you can see here that I am not correcting the patient. I'm just providing the patient additional information that they can then incorporate into how they're thinking about it. And we leave it to the patient to decide whether or not it makes sense for them. And you can also see that I didn't say here that your blood pressure or you are going to have a heart attack. I really try to leave it as neutral as possible so that the patient, again, is free to decide whether it applies to them. Okay. So now that we have this information, there's a tool that we can use in actually, giving it to them. So this is the Ask, Provide, Ask tool. And what it means here is that we're going to first ask permission to share this information with the patient. We're going to then provide the information. And then very importantly, we're going to ask what they think about what we just provided. And the response to that is when they respond to that, we're going to then reflect and summarize, because it really does depend on whether or not they feel that the information we provided was relevant or not. And so what we then do afterwards depends on that reaction. So let's go through an example here. Can I share with you some information about high blood pressure with you? And you let me know what you think. Patient says, sure. I provide the information about, I say, high blood pressure causes no symptoms early on, and that's certainly been your experience. But over time, that constant pressure weakens blood vessels. And at some point, weakened blood vessels can leak or burst, and a person feels it as a heart attack or stroke. What are your thoughts about this? And the patient may respond, wow, no one really explained it to me that way before. I guess it makes more sense why I would want to take the medication every day. So our reflection would be, well, yeah, you wanted to make sure that this was something that you needed. How would you like to proceed from here? So you could see how the Ask, Provide, Ask works here to engage the patient in a respectful way, maintaining the control with the patient, and we're just providing the information to the patient that's going to be useful for the patient to assess to revisit their sense making. Now, in this example, if the patient responds with, well, my job has unpredictable hours, and when I get home, my partner needs help with the kids. You're sensing here, what you see here is that even though we may have addressed the factual premise with this information and the importance for change has increased, what we're seeing here is that there's still this unaddressed motivational premise. And despite the importance being increased, their confidence is still low. And this is really important to remember, because if we are hoping to affect health behavior change, the sense of importance and confidence needs to be high, right? You can't have just one or the other. If a person feels like something is important to do, but they don't think they can do it, it's not going to happen. And similarly, a patient may have high confidence that they could change, but if it's not important to them, that change isn't going to happen either. So we really want to make sure that both importance and confidence are high. So that gets us to the motivational premise, right? So my life is hectic. What's important to understand here is that the patient is the expert, right? We are not the expert in the patient's life. The patient is. And so we cannot address this with medical facts. Okay. So this is where when we're working with the patient with a motivational premise, this is where the more typical skills of motivation interviewing that most of us have heard about really comes into play. So other examples here, as I mentioned earlier, is that with a person who has obesity, feeling embarrassed or eating when they're stressed, those are also, again, motivational premises. In the case of smoking, part of my routine, and all my other friends smoke, that's leading to the continued smoking. So these are additional examples. So what do we do? What is our approach to a person with a motivational premise? So I really encourage people to really think about this balance. What this is showing is change talk, or reasons to change, and sustain talk, which are reasons to not change. So all of us, our patients and us, when we're thinking about doing something or not, it all really depends on, what are the things that we are thinking about. If we are having a lot of, and in our mind having a lot of change talk, or thinking about reasons for change, then that behavior is more likely to occur. On the other hand, if our mind is filled with sustained talk or reasons not to change, we're simply not going to change our behavior. So our goal is making sure that we're asking the right questions. So how not to evoke change? Well, if we ask the patient, why don't you tell your partner you have to eat healthier? Or what do you like about eating junk food? Or if we start to tell patients, the risks of smoking are A, B, and C, and we're doing this in a very unsolicited way. Or finally, if we just simply tell the patient, you need to start cutting down on cigarettes, all the responses to these questions are going to be sustained talk. They're going to tell us why they can't change, right? So we have just short-circuited our intention, which is to help promote change. So how do we do this differently? Well, we do this by asking open-ended questions about the patient's desire, ability, reasons, and need for change. What would you like about change? How could you change if you did it? What are some reasons that you have for change? And what would you need for change? Or how important is it for change? And what we're trying to do is we're trying to elicit preparatory change talk, where the patient would respond with, well, I'd want to change for such and such reasons. I could start, if I did change, I could start by doing A, B, or C. If I did change, it would really help me with my health, my ability to walk. Or I know I'd have to change because I want to be around for my grandkids. So we are now asking questions that are much more likely to elicit change talk. And that's the idea of trying to tip the scale towards behavior change. Now, people often ask, well, okay, let's say the patient does tell me, okay, I have these reasons for change. What do we do then? Well, what we do is we now use our OARS skills that we were earlier using to explore. We're going to use them now with more intention. Okay. So when we hear change talk, we're going to ask for more change talk. So for example, if the patient says, well, I could start by doing A, B, or C, I'm going to ask for specifics. Oh, how could you do that? What would be the first step that you would take? In what ways would things be better if you did that? The answer to these questions are, again, more change talk. If the patient has made slight progress towards change, then I'm going to make affirmative statements about that change, that despite barriers, you've made some progress, or that you've done this and you care about your family. If I hear the patient telling me a downside of their continued behavior, I'm going to say, wow, you're really starting to see some downsides to that behavior. And the same thing for upsides. So when we hear change talk, we're going to respond specifically to that change talk by asking for more. And then in summary, when we summarize, we may want to collect a series of change talk that they've mentioned and put them together and present that to the patient and ask where they would like to go from here, right? These are not questions, these are not reasons for change that we've told them. These are the reasons that the patient has told us, right? And so once we're able to collect these different reasons and we present them to the patient, oftentimes the patients will reflect on that and say, wow, I've got a number of reasons to change. So back to our example, if the patient has said, well, my job is unpredictable, has unpredictable hours, and when I get home, my partner needs help with the kids, I might reflect back, you're really busy and wondering how to fit it in. Patient says, yeah, I'm just not sure how I can do it. I might respond with, what are some things that you do consistently every day, regardless of your job or kids? Well, I do brush my teeth every morning. I guess I think I could take it then. Okay, well, how confident are you that you could do that every morning? And in this particular example, the patient may respond, oh, 100%. At this point, I might summarize with, you want to do all the things you can to prevent a heart attack, which includes taking your medications every day. You had concerns about how you could do this, but feel confident that taking it when you brush your teeth will work for you. Am I missing anything? So in this short, simple example, we can use the same OARS skills to help the motivational premise move forward and evoke the patient's own reasons for change. Now, with that last open-ended question about the patient's confidence, that is an opportunity to use rulers. So this is something that can be very helpful in eliciting change for motivational premise. So you could ask, on a scale of 0 to 10, with 0 being not at all and 10 being extremely confident, how confident are you that you could take your medication every day? Now, if the patient had said, well, maybe about a 5, then you can respond with, oh, why are you at a 5 and not a 2? Or you could say, what would it take to go from a 5 to a 7? Or what might you need to go from a 5 to a 7? And the reason that these specific questions are asked is because the answer is actually calling forth more preparatory change talk. So what I mean by this is when I said, why are you a 5 and not a 3, they're going to tell me why they're not a lower number, which is change talk. And this is important because you don't want to ask, why aren't you a 7? Because if you say, why aren't you a higher number, they'll tell you sustained talk. They'll be telling you reasons why they can't do it. So it's important that you ask them why aren't they a lower number? So if we do this, we may be able to, again, increase the patient's confidence for change. Along with the darn questions, we're trying to help move this confidence parameter into higher than what it was. So how do we know when the patient is ready for planning? How do we know that? Well, we're going to be listening for CATS. So this is where CATS comes into play. We're going to be listening for commitment language. We're going to be listening for activation language, and we're going to be listening for evidence the patient's taking steps. So in our example here, for example, the patient said, well, I do brush my teeth every morning. I can take it then. So they're giving us activation language, and that is that's how that's my indication that the patient is mobilizing towards change. And at this point, it's very easy to leap ahead of the patient and start to really tell the patient what to do. But really, even at this point, we really want to know what their ideas are. And this is where, once you're moving and talking about change, it's important to think about the SMART goal setting. So this is the final tool. So that when a patient is thinking about change and is planning for change, we want to make sure that that plan is specific. So instead of just, I'll start exercising, is we want to ask about what specific exercise. And so the patient might say, oh, okay, I'll start walking. But then we want to make sure it's measurable. So instead of just start walking, we might ask them, how many times a week do you think you could do that? And the patient might say 3 times per week. We want to make sure it's attainable. So if the patient's going from sedentary to saying, well, I'll run 10 miles 3 times a week, we might ask them how confident they are about that. And we might help the patient get to a more attainable goal of walking around the block, for example. We also want to make sure it's whatever they do come up with is relevant. So that instead of saying, for exercise, well, I'll eat less salt, while that might be a good goal, it's not really relevant to the specific goal of exercise, right? And then finally, we want to make sure that the goal that they set at that appointment is something that is timely, that so that something, rather than something that they can start next month or next year, making sure that that step is something they can do much more earlier than that. Ideally, something they can do between this appointment and the following appointment. I want to just really emphasize that it's very easy for us to start to make recommendations of, oh, why don't you start walking? Why don't you, what do you think about riding a bike? And we may have the best of intentions, but it's motivational interviewing would say, we really want to start from asking the patient what they want to do rather than making suggestions right away. And then finally, plan for follow-up. I'd like to make an appointment with you in 2 weeks, 4 weeks, and we can, go over how this plan went. So that is, in a nutshell, some of the basics in this introductory lecture on motivational interviewing, kind of going over some of the technical aspects of when we use certain skills, when clearly motivational interviewing is much richer than what I have just presented today, with much more nuance, but that can be very overwhelming, I think, when we first start. And so I'm hoping that this basic introductory technical discussion is helpful in placing which skills we use when during motivational interviewing. Obviously, continuing to practice MI is really important, but I'm hopeful that this is one step along the journey towards using motivational interviewing in the future. Thank you for listening.